Erin Sizemore is a nurse practitioner in our practice. She's been with us now for nearly 6 years. She has joined us from University of Louisville. She has been a breath of fresh air for us. She brings a level of concern and expertise in the management of childhood illnesses to our clinic. We are again thrilled to have her with us, and she's going to be discussing urinary tract infections. Erin, it's all yours.
Thanks, Dr. Peppis. Let me get on here and share my screen. I'll be able to see that. Let's see. Do it. We're working on a couple of technical difficulties. Give us just a second. Do you need to get out of the way?
I can't see how to share your screen.
Should I minimize it?
Would you like us to share your screen?
Hold on.
We finally got it.
Okay.
Okay. Can everybody see that now?
Yes.
Okay. All right. So thanks, Dr. Peppis, for that introduction. And I'm excited to talk about UTIs and urinary problems with you all today. It's a big part of our practice. So we're going to be covering kind of the high points of all of this today. Okay, so I have no disclosures, no personal financial interests that I need to discuss today. So pediatric urinary tract infections are very common. They account for over 1.5 million visits to healthcare providers annually. About 2% of these patients are male and 7% are females. And they'll have about one UTI by the age of 6 years. Although overall females are more likely to develop UTIs because of their shorter urethra. Infant males, particularly those who are not circumcised, are at an increased risk in the first year of life of developing UTIs. We discuss cystitis and complicated and uncomplicated cystitis. So uncomplicated is limited to the bladder and typically occurs in children older than 2 years with no underlying medical problems or anatomic or physiologic abnormalities. Uncomplicated cystitis usually is caused by pathogens that are susceptible to commonly used antimicrobials. Complicated cystitis, on the other hand, is defined by coexisting upper urinary tract infections, multiple drug-resistant uropathogens, or hosts with special considerations. So we see this in immunocompromised patients. We'll see this with patients with vesicoureteral reflux, indwelling, bladder catheterization, malignancy, diabetes, patients with comorbidities. And so some things to consider with complicated UTIs. Most occur with fevers of 101 degrees Fahrenheit or above, but not always. I think we get in the trap of thinking that it's can't be a complicated UTI if there are no fevers presenting, and typically there are fevers, but not all the time. So we want to suspect vesicoureteral reflux, or VUR, with high-grade fevers or significant symptoms such as nausea, vomiting, flank pain, gross hematuria, children that are very lethargic, loss of appetite. Those are all things to consider that perhaps you're dealing with an upper tract infection. So pyelonephritis can occur when virulence factors such as P. lyme enable the bacteria to enter the kidneys in the absence of anatomic anomalies. So those actually allow the bacteria to climb the urinary tract, basically. So move from the bladder into the kidneys, even in the absence of reflux or possibly holding disorders with bladder problems, as we're going to discuss later on. There can also be fungal or viral causes of these UTIs also, so they're not always bacterial, so that's something else to consider. So E. coli, this just gives you a breakdown of the common bacteria that cause these UTIs. E. coli is the predominant bacteria that we see, which is normal in the stool. So these just gives you a breakdown of the inpatient and outpatient bacteria that are typically the problematic bacteria for these symptomatic UTIs. So basically there's a whole list of risk factors in pediatrics for children to develop UTIs. Their female sex, we talked about that because of the shorter urethra. Genetic factors, urinary tract anomalies, bowel and bladder dysfunction, we're going to talk about that. That makes up a big portion of our patient population in pediatric urology. Vesicoureteral reflux, sexual activity, and bladder catheterization. In addition to those for febrile young children. So I'm just going to touch on reflux here quickly, just to talk about the grades of reflux. So basically, grade 1, you can see just fills the ureter without dilation of the upper tract. Grade 2, reflux fills the ureter and the collecting system without dilation. Grade 3, reflux fills and mildly dilates the ureter and the collecting system with mild blunting of the calyces. Grade 4, fills and grossly dilates the ureter and the collecting system with blunting of the calyces. You may also see some tortuosity of the ureter. Grade 5 is massive reflux that grossly dilates the collecting system. You can see all the calyces are blunted with a loss of papillary impression, and intrarenal reflux may be present. And you can see the significantly dilated ureter and tortuosity of that. Here's just gives you an idea of where basically the ureteral orifices are located in these children with reflux. So you can see with reflux patients that ureteral orifice is higher than what it needs to be in the bladder. So bladder dysfunction, I'm sure that you all have had a lot of dysfunctional voiders. We see a lot of dysfunctional voiders. So avoiding dysfunction, I always joke with parents a little bit and say, just because I'm telling you your child is a dysfunctional voider doesn't mean your kid's dysfunctional. It just means they have better things to do than go to the bathroom. So we see this all the time. It's a general term to describe abnormalities in either the filling or the emptying of the bladder. It's common. It constitutes about 40% of our visits. In some children, bladder dysfunction is a component of bowel and bladder dysfunction, and it's classified as either non-neurogenic or neurogenic. The International Children's Continence Society is a global multidisciplinary organization of clinicians involved in the care of children with lower urinary tract dysfunction. They've defined common symptoms of bladder dysfunction. The definition of the symptoms only apply to children 5 years of age and older. So the symptoms of bladder dysfunction, so urinary frequency, we see this a lot of times, increased voiding up to 8 times per day. Decrease would be voiding 3 times or less during the waking hours. We see this a lot of times with kids who hold and they want to rush in and out of the restroom to get back to activities, so they're not really taking time a lot of times to empty their bladders. The reason I'm talking about this is because we see a lot of these patients that have been worked up for urinary tract infections, but their cultures have always been negative, but they have these persistent symptoms. So the reason I wanted to bring this up today was just so that everyone can see how closely these symptoms of bladder dysfunction mimic UTI symptoms. So urgency, nocturia, incontinence, hesitancy, weak urinary stream, intermittent stream, dysuria, straining to urinate, post-void dribbling, and holding maneuvers. So obviously when you think UTI, you think it hurts when you pee, you're peeing more frequently and you're peeing urgently, and you might even pee on yourself. So these are commonly misinterpreted as UTIs, and we see children come in and they've been put on multiple antibiotics, but their cultures have never grown anything. So it's just something to keep in the back of your mind. If you're seeing this child that comes back time after time with UTI symptoms, there may be something else going on besides bacteria or viral or fungal causes of this. It could be behavioral, or it could be because there's something neurogenic going on with the child's bladder. So patients with non-neurogenic bladder dysfunction, or Hindmans Syndrome, are more likely to have constipation, encopresis, and fecal soiling, referred to as bowel and bladder dysfunction. It increases the risk of UTI due to urethral contamination. So these again are a lot of your dysfunctional voiders, which also fall under the dysfunctional elimination syndrome umbrella of children who hold not only pee, but hold poop also, because they just tend to do both. They don't tend to differentiate a lot. A holder is typically for pee and poop. So here are the signs of holding. You can see the curtsy, the sitting on their heel. These are just common posturing things that you would see with children who are holders, pretty characteristic of dysfunctional voiding. So I put this slide in here because we have parents come in all the time and tell us, well, he goes to the bathroom, he takes his time. Are you in there with him? Well, no. Well, this may be what your child's doing if you're not in there with them, seeing that they're going to the bathroom. Kids typically have better things to do than go to the bathroom. So you may see this if you walk into the bathroom thinking that your child's peeing. So neurogenic bladder and UTIs, there are multiple risk factors involved with patients with neurogenic bladders that increase the risk of UTIs. So the big thing is incomplete emptying. CIC, altered afferent nervous system, frequent hospitalizations, chronic constipation, secondary to neurogenic bowel. Difficulties with hygiene, because a lot of these patients are limited. Range of motion is limited, hand dexterity. There's just a lot of things that affect their ability to stay clean. So that's something, and if they don't have family or they're getting to an age where the family doesn't, want to be in their private area all the time, then that's something that can definitely affect their hygiene. There's also medications that may increase urinary retention. Anticholinergics, we use these a lot in patients with neurogenic bladder to help control bladder pressures. Sometimes you may see that on some of our reports as low bladder compliance. That refers to the patient's bladder pressures. So if you have a high pressure bladder, the kidneys are going to be under more strain, and we obviously don't want that. Or if you have a child that has a lot of bladder overactivity, we prescribe these anticholinergics. And anticholinergics just basically also help preserve the bladder function and keep the bladder healthy over time. Bladder augmentation. In a representative study of asymptomatic patients, 95% have positive urine cultures. Stones will also frequently occur in the augmented bladder, which can also be a source of persistent bacteria. CIC frequently is needed for bladder management in these patients. So reasons that we do CIC and the reasons that we're talking about this so much with UTIs, we're going to get to as we talk about this, but these patients a lot of times don't need to be treated for positive urine cultures. And we're going to go into that in a little bit more detail. Overdistension of the bladder can result in the capillaries becoming blocked, preventing the delivery of metabolic and immune substrates to the bladder wall, resulting in the bladder becoming more vulnerable to bacteria present in retained urine. So not only are we trying to reduce the intravesical pressures and preventing bladder overdistension, by doing CIC, we're getting that stagnant bladder out of the bladder, and we're also helping increase the blood flow within the bladder. Which makes the bladder mucosa membrane more resistant to infectious bacteria and reduces the risk of UTI. So I think there's this, this misconception a lot of times that CIC increases the child's risk of UTI, and it does somewhat, but there's also much more benefit to performing CIC than just emptying the bladder. So I think it's important that we educate our families on those points also. UTI symptoms in CIC patients. So basically, dark colored or foul smelling urine isn't a great reason to treat a UTI in a CIC patient, because those things typically result because the child is not drinking enough. So what we want to do is educate those families. Education is huge with these families because they think, well, if the culture is positive, it needs to be treated. Well, not all the time. So these are symptoms that we would want to treat if these present in a patient that's performing catheterization. So fevers, particularly high-grade fevers of 101 or over, chills, suprapubic pain. Now that the suprapubic pain isn't a good predictor in these children because of depending on their defect level and how much sensation they have in the perineal and suprapubic area. Pain with cathing, again, that can be vary between patients depending on where their defect is. Changes in the urine consistency. You may notice increased sediment along with some of these other symptoms. There may be mucus present if this is a child with an augmented bladder, which is not uncommon. So that's another thing to think about. If this child has had a portion of the bowel, used in a bladder augmentation, you're going to see mucus in there. So those are important things to consider also. Some of these patients are kids that are developmentally delayed, cerebral palsy. Sometimes they just don't really have fevers. You may actually see more behavioral issues like increased anxiety. Some of our patients who have seizures, you may see increased seizure activity, flank pain, increased spasticity in hypertonic patients, autonomic hyperreflexia, malaise, and increased incontinence. Increased incontinence, again, you want to consider other problems that may be going on besides the urinary tract infection, for perhaps, as I mentioned earlier, that their bladder pressures are higher than what they need to be. They may be having a lot of bladder overactivity. So those are patients that we need to see on a consistent basis. And that's why we do our urodynamic studies, so we can keep a check on those bladder pressures. So when you're assessing these patients, the important things are, of course, onset and duration of symptoms, manifesting symptoms, specifically fevers with no other known symptoms, particularly in infants and toddlers, family history of urogenital anomalies and UTIs. There is a genetic link in patients with vesicoureteral reflux. We know that siblings who have siblings with reflux are about 30% higher chance of having reflux. So those are things to consider. Urine collection. So a catheterized specimen is best in children who are not toilet trained. Now, catheterization is really the gold standard for everybody, but you don't want to take a child who is able to pee and catheterize them. So obviously a clean catch specimen is going to be what you get in those kids. Try to avoid bag specimens if at all possible, because there's a high risk of contamination. A lot of times the perineal skin does not get prepped properly. It's either from people not being educated or being in a rush, just multifactorial reasons why that may not happen. But it's important, if a bag specimen is the only way you feel you can get it, to prep the perineal skin thoroughly to try to get as much of that possible contaminating bacteria off of the skin as possible before the bag is placed. Older toilet trained children, a midstream specimen is acceptable with proper clean catch technique. So it's really important that we make sure that our support staff is trained properly on how to instruct these families on how to do a clean catch. So, making sure they wipe correctly from front to back, peeing that first bit of urine into the toilet to wash away that bacteria that may be present in the urethra, and then catching, particularly in males, and then catching that midstream without touching the cup to the skin, which is kind of a balancing act whenever you have a kid sitting on the toilet, but nonetheless, that's the best way to get that. Always send a culture and sensitivity for any suspected UTI, regardless of the urinalysis appearance. Just because it's nitrite positive, yes, it's probably going to be a positive UTI, but we don't know what bacteria it is, and we don't know what antibiotics are going to treat that particular bacteria. So you may end up with a child getting multiple antibiotics and not getting better. Urinalysis is consistent with UTI. Why did I need to do a culture? So a 2016 study showed approximately 1 in 10 children with UTI symptoms and a positive urine culture had no pyuria on a centrifuge specimen. So Pseudomonas, Klebsiella, and Enterococcus were more likely to be the identified bacteria in these cultures. These interestingly enough, are the ones that are at the increased risk of renal scarring with these bacteria. So you have bacteria that aren't going to particularly produce this pyuria, but may increase your child's risk of renal scarring if that bacteria reaches the upper tracts. Nitrites are more common in urine that has been stored in the bladder for 2 hours or more. So remember your holders. Whenever you're checking nitrites, yes, that's an excellent predictor that your culture is going to be positive, but that nitrite result may be skewed if you have a child that holds their urine for multiple, they only pee 2 or 3 times a day. That urine may have been sitting in there for several hours. So that's another important consideration and a reason to send a culture to verify what you're seeing on the urinalysis of the urine dip. When in question culture, formal urine culture is considered positive for UTI when the colony count is 50,000 or greater of a single pathogen. That has been changed. It used to be 100,000 colony count. It's now 50,000 or greater. So that's I'm sure most of you are familiar with that, but I wanted to bring that to your attention. If you don't culture, how do you know what bacteria? Is the treatment appropriate? What potential prophylactic antibiotics should we use? What if the child is still symptomatic after the initial treatment course of the empiric antibiotic? So it's really important to identify what we're treating and make sure we're treating it correctly. And then also, from our standpoint, whenever we see a child that's had recurrent urinary tract infections, or we suspect this child may have VUR, it's important we look back and we see what resistant bacteria have been produced on their cultures so that we can more appropriately treat them. It helps guide our treatment as far as prophylaxis goes. Or if we have a patient being referred to us who has recently been treated for a urinary tract infection, they come into the office and they still look positive, we know we're probably going to choose a different antibiotic than what they just completed to change therapy. So all of those things help guide us on how to treat these patients appropriately. So the AAP guideline for febrile UTI diagnosis, we talked about this, the presence of at least 50,000 colony count obtained by catheterization or suprapubic aspiration. I don't think too many of us are going to be doing suprapubic aspiration in the offices, but it's just important that we make sure we collect the urines appropriately and in the best manner possible. Antimicrobial therapy. When initiating treatment, the route of antimicrobial administration should be based on practical considerations. Initiating treatment orally or parenterally is equally effective. The clinician should base the choice of agent on local antimicrobial sensitivity patterns. So again, just basically get that culture and sensitivity so you know what's there. The duration of antimicrobial therapy should be 7 to 14 days. So when is referral appropriate? You all may have some of those questions. History of 1 or greater febrile UTIs manifested by fevers of 101 degrees Fahrenheit or above, and also confirmed with a positive urine culture. Also 3 or more culture positive afebrile UTIs over the last 12 months. History of unresolved dysfunctional voiding. Symptoms mimicking UTIs in the absence of a positive urine culture, and suspected neurogenic causes of UTIs or symptoms. And that's it. That's all I have. So thank you all. And I'll here for questions if anybody has any questions.
Aaron, I have a question.
Mm-hmm.
When should VCG be performed after a urinary tract infection?
When should a urinary VCG be performed?
After a UTI.
Okay. So basically, if you have a child that has had culture positive, particularly an infant, if you have an infant that has had a culture positive febrile urinary tract infection, we'd want to perform that. Pretty much, I mean, if we have a kid that comes in with 1 or 2 UTIs that have been febrile, that's been referred to us, you can pretty much be sure they're going to get a VCG.
So the timing of the VCG has traditionally been 4 to 6 weeks after a UTI. Is that what we should continue to do?
Yes, you want to make sure that the UTI is completely treated before performing a VCG. If the VCG is performed while the child is infected, you have a potential to push that bacteria up into the kidney if it's not already there.
Are there any questions from the audience that are out there? While you're typing them in, I have another question, and that is, at what part of the physical examination can lead you to believe that the child might have a neurogenic process going on?
So one of the examination points that we always do in our office is we check the lower back and the top of the gluteal cleft. So if there's a dimple, if the top of their gluteal cleft, if it looks like a V, if it looks like it veers off to one side or the other, those can all be physical exam findings that may indicate that the child may have a neurogenic process going on. And we may consider an MRI of the LS spine at that point, a urodynamic study for further evaluation.
Thank you. Any other questions from the audience?
What about, what about instead of doing BCG, when do you recommend the ultrasound to be done?
In ultrasound, if a child has had a febrile urinary tract infection, or if they've had more than 3 afebrile urinary tract infections in a year, I would recommend getting an ultrasound, see if there's any dilation of the kidneys, see if the bladder is emptying, see if the bladder, if it looks like there's anything going on with the bladder that could be indicative of maybe there's something going on.
Do we need to do that on one urinary tract febrile or symptomatic urinary tract infection? Should we get an ultrasound on every one of those children?
I don't think for an afebrile urinary tract infection you should, but for a febrile, if it's a culture positive with fevers of 101 or greater, I would say yes. Dr. Pappas, do you have any other thoughts on that?
I agree.
Okay.
And lastly, you said send for a culture, sort of even if the urine looks normal. Does that mean if you get a urinalysis and there's no nitrites, no white cells, no red cells, do you need to culture that?
If you're suspicious enough of a UTI with their symptoms that you're going to treat them with antibiotics, yes, I would send a culture.
Go back and finish my answer from the ultrasound. The reason that I would get ultrasounds earlier, and that's just my practice, is because it's painless and give you some information, because UTIs can be associated with urologic anomalies. However, VCUGs are not painless, and they're somewhat disturbing invasion. So I like to wait on those, like most of you all do, on a little girl for 2 UTIs, or a febrile UTI, and boys UTI who have been circumcised. If not been circumcised, then we teach the parent how to appropriately clean the foreskin to minimize the risk of that. There is a question out here, Aaron. It says, what are the commonly used antibiotics for UTI treatment?
What are the common antibiotics? We typically start out with Bactrim or Macrobid. Those are the 2 common ones that we typically use. We also use Keflex, sometimes amoxicillin, not too much amoxicillin because you see a lot of resistance to amoxicillin, but usually Bactrim and Macrobid I would say is what we usually start off with, but we do use Keflex, Augmentin. But those are our 2 top ones, and that's what we typically use for prophylaxis also, our Bactrim and Macrobid.
The only change in that would be a child less than 3 months of age. And if you don't want to use Macrobid, Macrodantin or Septra, and those children will go with Keflex or amoxicillin, primarily amoxicillin.
Another thing I wanted to touch on was the test of cure. I don't know if anybody has any questions about test of cure. I know we do see some patients that get tests of cure. If your patient is being treated for a UTI, you should see significant improvement in their urinary symptoms within 24 to 48 hours of initiating antibiotic therapy. So if your patient has improved as expected, they've responded in that 24 to 48 hours of their symptoms improving, and at the end of their course of therapy, there's no symptoms, that's not something that you need to do on a routine UTI.